Good morning. Today we're going to discuss about acute bacterial meningitis, one of the major health problems specifically in developing country. What do we expect out of this lecture? That at the end of this discussion is to be able to identify the list of the common etiological agents of acute bacterial meningitis, understand a little bit about the epidemiology, and discuss the pathogenesis as well as the laboratory diagnosis of acute bacterial meningitis, and how you can, what are the different modalities of therapy, as well as what are the avenues of preventive this kind of infection. This is what we're going to discuss today's lecture. Acute bacterial meningitis, as you know, is is an acute purulent infection within the subarachnoid space of the central nervous system. So all the three meninges of the brain gets infected with different kinds of bacteria, and it is covered with, and over a period of time, if not treated properly, it will be covered with pus, and it will affect a large part of the different parts of the brain, and resulting in severe neurological deficit in at least some of the individuals. Epidemiologically, if you look at the world data, about 1.23 million individuals suffer from acute bacterial meningitis almost over the whole of the world, but mostly this disease is seen in the third world countries, the poor developing country, and approximately about 135,000 deaths all over the world. As I told you, this is one of the major health issues that can be prevented, at least with the vaccination and therapy. A large amount of mortality can be reduced. One of the major issues with this disease or acute bacterial meningitis is that about 30 to 40% individual who recover from acute bacterial meningitis will have permanent kind of neurological disabilities. First, let's understand what the nature of the protection in the central nervous system. As you already know, the brain is encased within the skull and the connective tissue, and it is also protected from the blood by blood-brain barrier. And within this space, there is a place called subarachnoid space. That means the space below the subarachnoid matter, as well as and the pyometer. The fluid filled space is called subarachnoid space, and this subarachnoid space is filled with this is cerebral vascular CSF or cerebrospinal fluid, and this cerebrospinal fluid actually covers the whole of the brain, give it some kind of a cushion, and it also collects nutritions or the metabolic products of the brain cell, and then it joins the lymphatics and drains out into the venous system. The major issues that we are concerned about, that within this cavity of the bony cavity or the isolated cavity in the CNS, there are very few immunoprotection that is available if you compare to the periphery. In the periphery, you have a robust amount of immune protective mechanism, but inside the brain, inside this skull cavity, inside the CNS, very few complements are there, very few blood cells are there, 0 to 5 WBC, and fewer immunoglobulin molecules. Therefore, if the bacteria or if any kind of bacterial agents or viral agents or fungal agents or parasite gets an entry, it can cause a havoc. As I already told you, that the brain has three layers. The pyometer is just immediately over the brain. Then you have the subarachnoid, arachnoid matter, and finally you have the dura matter. Then you have the skull, bone of the skull, soft tissue, etc., etc. So this space between the arachnoid and the pyometer is called the subarachnoid space, and this is a space where the bacteria fungi, etc., causes infection, causing severe purulent kind of inflammation in this, and in this process this will get greatly affected, and since this space is continuous with the spinal cord, so it will affect most of the central nervous system as well as peripheral nervous system. Let's quickly look at this cerebrospinal fluid. Cerebrospinal fluid basically is filled in the subarachnoid space. As I already told you that the cerebrospinal fluid is basically filtered from the blood through the ependymal cells of the choroidal plexus, as well as the subarachnoid granules that you see, subneural capillaries that you see in the subarachnoid space, arachnoid granules in the subarachnoid space. So the CSF that is produced, 60% is by the choroidal plexus in both the ventricles. Both the ventricles contains about 25 ml each, and then you have the rest of the ventricles about 100 to 150 ml. So a total of 150 to 200 ml of fluid will be cerebrospinal fluid will be present at any given point of time. In a day, totally about 500 to 700 amount of fluid will be secreted inside this subarachnoid space, and subsequently it will be drained into the peripheral venous system. Why is it important to understand this subarachnoid space? Is that this subarachnoid, as I already told you, that this particular space it borders between directly on the brain matter, and it prevents the blood flow from the rest of the peripheral circulation. At one point of time, it was thought that this brain is a closed space and it is immunologically inert. That means it is a very isolated, just like the testes or the other closed organs where immune cells cannot get an entry. It's an isolated space, closed, isolated, protected space. The whole idea was that if there is any kind of infiltration of the inflammatory cells, it will damage the post-mitotic neuronal cells, terminal neuronal cells, which will be which will cause severe damage because these cells are not non-generating. Secondly, it was thought that CNS immune response is not essential because robust peripheral immune system is supposed to almost protect the individual from any kind of microbial invasion. So because of these two hypotheses or thoughts, it was thought that the brain is a closed space, but now we understand that it is not so. So there has been a paradigm shift in our understanding of the immune system in the CNS. First is that the immune system in the CNS, in terms of antibody, natural antibodies, specific antibodies, as well as the resident immune cells that are present, like microglial cell astrocytes, are necessary for the maintenance of the growth and repair of the normal physiological function of the neurons. Therefore, immune response plays a protective role for neuronal steady states. So in a normal steady state, now we understand that you require a certain amount of immune cells from the periphery that is specifically trained to circulate inside the brain, along with the resident immune cells, microglial cell, pericytes, astrocytes in the brain, is necessary even in a state of physiologically normal state. Let's look at what are the different immune components inside the brain before we get into the pathogenesis of the acute bacterial meningitis. As I told you that peripheral immune system is composed of basically innate immune system and the adaptive immune response. And the innate immune system, the soluble and insoluble and cellular components are there, like the complement, the and then you have the different enzymes, proteins, C-reactive protein, so on and so forth in the innate immune, and eosinophil, natural killer cell, basophil, monocyte. These are part of the innate immune system. Whereas in the adaptive peripheral system, you already know that there is specialized T cell immune response as well as the B cell immune response for antibodies. So in the peripheral component, you have both the cellular as well as the humoral immune response as well as the innate immune response. But inside the CNS, as I already told you that if you compare the peripheral immune component to the central nervous system, the immune system is very almost like a rudimentary, but it still exists because, as I told you, normal physiological state, you require these immune cells inside the brain for the normal physiological function of the and the maintenance and repair of the neuronal cells. So we have microglial cells. These are the spider cells covering almost whole of the brain. In fact, the number of the microglial cell per gram of tissue in the CNS is about 8 to 9,000 cells per gram of neuronal tissue. Astrocytes, pericytes. What are the function of these cells? Function of these cells are that they keep on sensing the environment of on the surface of the CNS, and they will look for any kind of pathology on the surface of in the brain, and then try to control it without much inflammation. In addition to this, you also have importantly the blood-brain barrier, because the blood-brain barrier, or as we call it, a neurovascular unit, it will separate the peripheral vascular system from the subarachnoid space and the brain. And this is the most important part, because if the blood-brain barrier is compromised, then all hell will break loose and the bacteria will get an entry into the CNS. So what is the role of the immune cells? Just to recapitulate, as I already told you, now we understand that the immune cells in the CNS, including the circulating very low number of B cell and T cell macrophages, monocytes inside the cell, as well as the resident immune cells like the microglial cell, astrocytes, they are important for maintenance of the steady state. They will be important for maintenance of the neural tissue, repair of the neural tissue. They are important for repair of the trauma injury to the brain, and they are important for protecting against the microbial infection. They are important for monitoring the surface of any kind of change, the appearance of a tumor or appearance of multiple sclerosis, abnormal protein, etc. So if the resident cells within the brain will try to protect the brain, if there is a small plaque of amyloid, it will slowly start to remove it by the macrophages or other cells, and slowly it will try to control the pathology inside the brain. Quickly look at what is a blood-brain barrier, or what is a neurovascular unit that is called the blood-brain barrier is now called a neurovascular unit. So basically, it is a structural and functional barrier between the blood and the CSF. Importantly, it fulfills two functions. One is that it acts as a physical barrier. You already know that the blood has a huge amount of different protein components, a large amount of enzymes, large amount of nutritional components, metabolic products. So it acts as a selective exchange barrier. So it doesn't allow, because otherwise, if this component gets into the blood, then there may be a severe reaction inside the brain. So let's quickly look at what are the components of the blood-brain barrier. If you look at the vascular epithelium from inside to neurovascular epithelium, from neurovascular entity from inside to outside, you have the neurovascular epithelial cell, you have the neurovascular basement layer, and on the outside you have the microglial cells extending its spider-like pseudopodia, and you have the astrocyte, you have the pericyte that covers the surface of the neurovascular unit. So any point of time, any organism, like suppose for example malaria or any bacteria like meningococcus, enters into the neurovascular unit and it is attaches to the blood epithelial cells, then these microglial cells or astrocyte or pericyte is able to sense the invasion of the bacteria in this compartment, because these epithelial cells are capable of inducing adenosine molecule. They are capable of inducing different kind of cytokines, and these cytokines, adenosine molecule, will attract large amount of different kind of inflammatory cells or immune cells to the site, and these immune cells, and if the organism gets into the subarachnoid space, these immune cells will follow and try to control the infection. So in what are the conditions where a blood-brain barrier can be compromised? In a normal state, individual with very high blood pressure, neurovascular stroke, and if there is a developmental defect, if there is excessive hyperosmolarity, if there is microwave injury, if there is a severe radiation injury, if there is infection, if there is ischemia, if there is a fracture, these are the conditions where the blood-brain barrier can be compromised, and the peripheral, there will be connection between the subarachnoid space and the peripheral vascular system. We have to understand that in the peripheral immune system, once the bacteria or the virus or protozoa gets inside the peripheral immune system or peripheral vascular system, then the antigen or the microbe is recognized by the antigen presenting cell, and the antigen presenting cells either engulfs the microbe, process it, it is exposed with the antigen, exposed along with the MHC class 1 and class 2 molecules, and it is presented to the B cell and T cell in the peripheral lymphoid tissue, and an immune response is mounted, and the organism is killed or it is phagocytosed by a specific cell or by a specific antibody. If the microbes somehow gets entry either through a macrophage or a T cell inside the brain, this can cause severe infection in the subarachnoid space, and from the subarachnoid space it can directly affect the brain. As I told you, the resident resident immune cells inside the brain, the microglial cells and the astrocytes, they are also capable of inducing a large amount of cytokine. They also express MHC class 1 and class 2. So once these cells recognize the microbial antigen, they will induce production of cytokine, chemokine, etc. And they will activate the mast cell. They will also cause transportation of the macrophages and T cell into the subarachnoid space over the brain, and this will cause severe exudate, and it will cause tissue damage. If a very small amount of organism, the brain will try to protect, but if the organism like Streptococcus pneumoniae or meningococcal meningitis or Neisseria meningitidis gets inside the brain, they will replicate, or they will divide in large numbers, produce large numbers, and they will outnumber the immune system inside the brain, and therefore cause severe inflammation. So what are the conditions where this can happen? So in case of infection, in case of trauma, the reactive oxygen radicals or substances or the matrix metalloproteinases or angiogenic factors, inflammatory cytokine, autoantibodies, leukocytes, adenosine molecules, immune cell extraversion. These are the conditions where the blood-brain barrier can be breached, and as a result, the fluid will slowly seep into the subarachnoid space, and the subarachnoid space will be the neurovascular unit will be more permeable. The intercellular junction between the epithelial cells will be broken, and the impaired transporter function will be there, and parasite detachment will be there. All this will lead to an impaired blood-brain barrier neurovascular unit, resulting in imbalance of ion and transmitter, leakage of plasma protein into the subarachnoid space, entry of different toxin pathogen directly into the CSF, into the subarachnoid space over the brain, microglial as well as the astrocytes will be activated. They will produce large amount of cytokine, and this will cause severe damage on the neuronal dysfunction, because this will produce, as you realize, once the organism invade the meninges or into the brain, because there is very few immunoglobulin molecules, there are very few WBC, but there is a large amount of, there is sufficient amount of sugar for the organism to multiply. So they will grow into large numbers. Some of the bacteria will, over a period of time, will break down. They will produce endotoxin, and the other component of the bacterial cell will produce inflammatory cytokines. These inflammatory cytokines will alter the blood-brain barrier. More leukocytes and inflammatory cells will pour into the inside the brain by breaking the blood-brain barrier, either through the intercellular junctional or by direct penetration of the the basement membrane of the neurovascular unit. And this leukocyte migration will cause severe amount of leakage of proteinaceous material into the subarachnoid space, and this subarachnoid space, with a huge amount of exudates on the surface, and will cause destruction of the WBCs, RBCs inside the brain, and it will cause severe adhesion in the subarachnoid space, leading to blockage of the CSF outflow and causing severe ischemia, because it will pressurize it will cause necrosis or ischemia in the blood vessel. The blood vessel will stenose, and it will cause lack of blood flow into the brain. So there will be a cytotoxic edema, stroke, seizure, and this will invariably lead to intracranial pressure. And finally, because of the intracranial pressure as well as the severe outflow obstruction, the individual may go into coma, or it may also result into cell injury, infarction in a part of the brain, causing blindness or causing deafness. And this is the reason why 30 to 40% individual who is suffering from acute bacterial meningitis will invariably end up with neurological deficit. Let's quickly look at what are the commonest etiological agent of acute bacterial meningitis. Commonest bacterial cause of acute bacterial meningitis are Streptococcus pneumoniae, Neisseria meningitis, Haemophilus influenzae, Staphylococcus aureus. Mycobacterium tuberculosis cause chronic infection. Along with this, specifically in the neonates or newborns, you have Escherichia coli, you have group B streptococci, you have Listeria monocytogenes. These organisms are specifically associated. It's not that they cannot cause infection in the adults. They can cause infection in the adult, but mostly these are the three organisms which are associated with neonatal meningitis. What are the factors, very briefly, associated with neonatal meningitis? Prematurity, prolonged rupture of membrane, low birth weight, maternal perinatal infection, prolonged and difficult labor. These three organisms, E. coli, group B streptococci, and Listeria monocytogenes, can colonize the vaginal flora as a vaginal flora or the birth outlet, and as the child is born, the organism can infect the newborn, or it can ascend to the uterus through the ruptured membrane and infect causing the early neonatal meningitis. So neonatal meningitis specifically can be divided into early onset and late onset. Early onset, we call it early onset because it occurs within first week. That means that it is transmitted either during the birth canal, delivery through the birth canal, or ascending bacteria from the vaginal cavity. Or the late onset occurs normally from 3 to 4 weeks onward, and because it is mostly transmitted from the health care workers who are taking care of the baby. So in case of early onset, neonatal meningitis, transmission is through vertical transmission, whereas in case of late onset, it is acquired through horizontal transmission through nurseries or hospital personnel or through the immediate caregiver. In case of neonatal meningitis, the manifestation is slightly different than the adult, which we are going to discuss in a little while. But what about the acute bacterial common predisposing factor in the adults? Mostly the predisposing factor in the adult acute bacterial meningitis are immunocompromised state. If the individual is suffering from thalassemia and he has a splenectomy done, so in those individuals with asplenic state where the spleen is not there, capsulated organism like Streptococcus pneumoniae, Haemophilus influenzae, Neisseria meningitis, Listeria monocytosis can cause severe infection. If there is a basal skull fracture during a road traffic accident, the organism can penetrate through the broken temporal bone. For organism like Streptococcus pneumoniae, which can be present either in the eustachian tube or it can through the external auditory meatus or through the middle ear infection, it can get transmitted. Post neurosurgery head trauma, commonly infective organism or Staphylococcus aureus or any kind of gram-negative hospital organism can cause infection in this particular group of post neurosurgery cases. And commonly associated, hospital associated acute bacterial meningitis that we see is associated with cerebrospinal fluid shunt. If a child is born with severe hydrocephalus and the shunt is implanted, over a period of time this shunt may be colonized by Staphylococcus epidermidis, Staph aureus, or Pseudomonas or Acinetobacter. So these are some of the common predisposing conditions in case of acute bacterial meningitis. The etiological agents I already told you. The few common bacterial agents that cause acute bacterial meningitis are Streptococcus pneumoniae, repeating again, Neisseria meningitis, which is cause epidemic as well as sometimes pandemic infection, Haemophilus influenzae, a common agent of infection in the early childhood, Staphylococcus aureus. In addition, as I already told you, E. coli, group B Streptococcus, as well as Listeria monocytogenes. So these 6 or 7 organisms are the commonest organism that causes acute bacterial meningitis. Just very briefly, looking at the individual organism, Haemophilus influenzae, we already have read that it's a gram-negative bacteria. It has several serotypes, out of which 6 different serotypes, out of which serotype B is the most common because it carries a very pathogenic type of polysaccharide capsule, which is composed of polyribitol ribose phosphate. And because of this polyribitol ribose phosphate, it is one of the most virulent Haemophilus influenzae. The other types of serotypes of the organisms like A, C, and F and non-capsulated varieties cause lesser number of acute bacterial meningitis, but most of these infections are Haemophilus influenzae meningitis are seen in children below 5 years of age. This I already told you that the pathogenic determinants of Haemophilus, the most important component is the polyribitol ribose phosphate, the PRB capsule. It inhibits complement engulf or opsonization. It helps to survive the bacteria inside the macrophages and or monocyte, and through the monocyte macrophages it can enter the blood-brain, it can breach the blood-brain barrier and enter the subarachnoid space. So as you see, Haemophilus influenzae infection basically is a disease which is associated mostly in the developing country, that is mostly in the Africa has the highest number of infections, then more than 2,000 per 100,000 population. India also has a very large number of cases. 100 to 1000 to 2000 per 100,000 population. The Southeast Asia, the countries like Burma, Bangladesh, Indonesia, Laos, Cambodia, Vietnam, these are the countries where Haemophilus influenzae meningitis is quite frequently seen. After the excellent vaccine of conjugate vaccine of against Haemophilus influenzae type B, as you can see, this is post-vaccination period and this pre-vaccination period. So after this vaccination that has been introduced in 1995 onward, the acute bacterial meningitis because of Haemophilus influenzae type B has drastically been reduced. It has been seen in almost all parts of the world. Haemophilus influenzae type B acute bacterial meningitis is almost now has come down to negligible level. The second important cause of acute bacterial meningitis is Streptococcus pneumoniae. We already know that it's a gram-positive bacteria. It has more than 90 different types of capsular polysaccharide, and this capsular polysaccharide is the most virulent component of the bacteria. As you see, again, the disease has the highest number of cases in the developing country like the African countries or the Indian subcontinent, Pakistan, Afghanistan, and the part of the Southeast Asia. This is where you have the huge number of cases of acute bacterial meningitis or pneumonia due to Streptococcus pneumoniae. As I told you, there are more than 90 different capsular serotypes of this organism, but there are only few serotypes like serotype 14, 19F, serotype 5, serotype 6A, serotype 6B, serotype 1. These are the common serotypes which are causing majority of the infection, and now you have an excellent vaccines against this serotype, both capsular vaccine as well as a conjugate vaccine. The third most important cause of acute bacterial meningitis is Neisseria meningitidis. Neisseria meningitidis is an organism which is gram-negative. Diplococci is aerobic, it's catalase oxidase positive, and it is present mostly in the throat, and human is the only carrier. So this organism survives during the interepidemic period in the throat of the individuals, and the carrier rate can be vary anywhere between 5 to 10% during the interepidemic period. So Neisseria meningitis is a major cause of acute bacterial meningitis in almost whole of the world. The other important thing about epidemiology is that this organism is also seen in large number in cases of acute bacterial meningitis from developed countries like US, Russia, or the European countries. So it is a colonizer of the nasopharynx, and from the nasopharynx it can be transmitted to the subarachnoid space either through the inside the monophase macrocyte, or it can sometimes directly invade the blood-brain barrier. So there are more than 13 different types of serogroups of Neisseria meningitidis, A, B, C, D, etc., out of which A, B, C, Y, W135 are the most commonest. Out of which in India, specifically serogroup A is responsible all the outbreaks that has happened in Indian subcontinent. As I already told you that in any individual who doesn't have a spleen or had a splenectomy done, in this individual, because there is lack of complement, this capsulated organism like meningococcal Neisseria meningitidis, Staphylococcus aureus or Streptococcus pneumoniae, Haemophilus influenzae can cause severe disease, invasive disease. So Neisseria meningitidis, as I already told you, that Indian subcontinent it is the serogroup A, whereas in the temperate climate like the United States or the European countries, it's the B and C that are mostly responsible for Neisseria meningitis infection. The other important thing you have to understand that a huge number of acute bacterial meningitis cases occurs in the sub-Saharan countries. The Sahara is a desert across the length and breadth of the Africa, and this area every year or every few years you have a huge large number of acute bacterial meningitis cases is observed due to Neisseria meningitis, and this Neisseria meningitis causes severe morbidity, and as many as 8 to 10,000 cases per 100,000 population has been seen during epidemic period. The other endemic belt that we commonly see is the North India. So these are there is a lot of similarity between these two areas geographically as well as climate wise. Probably that's why these two areas are you have a large amount of epidemic outbreak. Specifically for India, and there has been many outbreaks of acute bacterial meningitis due to Neisseria meningitis. For example, in 1934, in 1965, in 1985. Recently, as recent as 2005, we had several outbreaks of Neisseria meningitis due to serogroup A. So meningococcal meningitis can be of two different types. One is that you have plain acute bacterial meningitis, only CNS is involved. The organism may be present in the blood, but if it is present in the blood in large numbers, it can cause meningococcemia with hemorrhagic manifestation. So you have a meningococcemia as well as you have a acute bacterial meningitis. Sometimes you can have the individual can have hemorrhagic spots with high septicemia or a high grade of fever, and if you take a skin scraping or a blood scraping from these spots, you should be able to identify the organism in a gram stain. That is the Neisseria meningitis. Staph aureus, as you already know, this is an organism which is capable of causing a large number of different kind of infection, including subacute bacterial endocarditis, pneumonia, acute gastroenteritis, a large number of different conditions. But mostly in the post neurosurgery unit, Staphylococcus aureus is the commonest cause of acute meningitis. Following neurosurgery, if the organism is circulating in the ward or on the hospital, if it is specifically against resistance against methicillin group of antibiotic, then it will be very difficult to eradicate. But this is one of the commonest cause of post neurosurgery acute bacterial meningitis in a hospital setting. So what are the different signs and symptoms of acute bacterial meningitis? Acute bacterial meningitis is commonly said with severe headache, high grade of fever, neck and back stiffness. The patient will not be able to, he will have photophobia, he will not be able to expose himself to light. He will have severe neck and back stiffness, he will not be able to bend his neck, and there will be specific sign like Brudzinski sign or Karnik sign that will be positive. What is Karnik sign? If you lift the leg in a flex knee position and then try to extend the lower part of the leg, then there will be severe hamstring pull here, and the patient will almost cry from the pain. This is called Karnik sign. So here the clinician is trying to extend the leg on a flexed knee position, and it is caused severe hamstring spasm. The Brudzinski sign is that when the patient is lying in a supine position, if you try to bend the neck, automatically the knee will also get flexed, because this is the meninges are severely irritated, inflamed. Therefore, this reflex is called Brudzinski sign. The other thing you have to understand is that these signs, acute bacterial or bacterial meningitis in the adult individuals, may not be similar to that is present in the newborn or infants. In newborn and infants, one may or may not get the similar kind of picture of say neck rigidity, the photophobia, etc. In this individual, fever, irritability, lethargy, poor feeding, high pitch cry, bulging fontanelli, convulsion. These are the common signs and symptoms of acute bacterial meningitis. So if you see a small child or a newborn coming to the OPD or casualty with mother complaining the child is not feeding, the baby have a poor feeding, he is crying all the time, high pitch cry, his fontanelli is bulging, so one can take a blood sample for blood culture and you can suspect that the patient individual may be suffering from early neonatal infection, acute bacterial meningitis. What are the complications of meningitis? As I already told you, that 30 to 40% of these individuals suffering from acute bacterial meningitis may have residual neurological deficit. In addition to that, septic shock associated with endotoxic activity of the bacteria that can cause disseminated intravascular coagulation. It can cause severe cerebral edema. It can cause severe seizure, arteritis, venous thrombosis, subdural effusion. In case of babies, specifically, it can cause hydrocephalus, sepsis, brain damage, deafness, blindness, etc. So this is the reason we must be very careful that this individual suspected of having acute bacterial meningitis must be immediately diagnosed and put through the laboratory diagnosis. So what are the different modalities of laboratory diagnosis of acute bacterial meningitis? The most important diagnostic, of course, is the identification of the organism, and this is done through blood culture. You take a blood sample, or you do a lumbar puncture, that you put the needle in the lumbar between lumbar 3 and 4 or lumbar 4 and 5. You put a needle and you take the CSF fluid. As I already told you that this is CSF in the subarachnoid space is the place where the bacteria is multiplying, and this fluid can be collected from the number of cell counts. As I told you, normally in normal physiological status, the number of WBC in the CSF is 0 to 5, only 0 to 5. Whereas similarly the blood glucose level is about 2/3 of the glucose level in the CSF is about 45 to about 80 milligram. Similarly, protein is about 15 to 45. So in case of acute bacterial meningitis, when you collect the CSF sample, this should be subjected to cell counts to see whether the WBC has increased, whether the blood sugar level, the CSF sugar level has gone down, because the organism will utilize the glucose for multiplication as well as metabolic activity, and the protein level will go increase because the blood-brain barrier will increase. Also, the bacteria will multiply and produce large amount of protein. So you will have in the lumbar puncture, and the amount of the pressure of the CSF when you take the lumbar puncture will be very high. Normal pressure of the CSF is about when the patient is lying down, maybe about 150 to 100 millimeter of water. If the patient is standing up, the pressure might be slightly on the higher side. When the patient is standing, which might be normally about 200 to 300 millimeter. But in a lying position, if the pressure is, if you see the CSF fluid ejecting with a very high speed and falling into tube and falling outside, you know that the individual has developed some kind of a severe cerebrospinal outflow obstruction. So high CSF pressure, very large amount of WBC in the CSF, low glucose level in the CSF, high protein level of in the CSF. These are some of the indication that the individual may be suffering from acute bacterial meningitis. So we will take a sample for biochemistry. We will take a sample for gram strain and the culture. You will take a sample for cell count and different cell count, and the fourth tube for PCR polymerase chain reaction for identification of the, if it necessary. So as I told you, the normal pressure is about 100 to sometimes it's 50 to 100 millimeter of 180 millimeter of water. In case of acute meningitis, because it is a huge amount of protein and the WBC, it will become very cloudy. The cell count maybe go as high as 10,000 per millimeter of per millimeter of blood, CSF fluid, predominantly polymorphonuclear leukocyte, because it is acute bacterial meningitis. The sugars will be low, whereas the protein will be pretty high. Protein will be elevated. So in case of, if you look at the table, as I told you that in normal CSF, the CSF is clear, the pressure is 90 to 180 millimeter of water, the WBC about 0 to 5, somebody takes sometimes someone also takes it, the upper level is 8. The protein level is about normal 15 to 45 milligram per deciliter. The glucose level is 50 to 80. In case of acute meningitis, the fluid will be turbid because there is large amount of protein, large amount of WBC. The pressure will be increased, as I already told you. The WBC or white blood cells because of the blood-brain barrier will be compromised. A large amount of WBC monocyte macrophage will penetrate through the blood-brain barrier and infiltrate in the subarachnoid space. So he has a huge number of these cells in the CSF. Protein level, as I already told you, because of the extravasation of the blood into the subarachnoid space, you have a large amount of protein, and the glucose will be low because the organism will utilize the glucose. So CSF sample which is turbid, you should suspect acute bacterial meningitis. One can do gram strain, although as I have been telling all the time that the number of bacteria to be present in the CSF to be positive by microscopy would be about 10 to the power 6. So there has to be 10 to the power 6 per ml of fluid in the CSF to be positive by in the gram strain, which means that a very large amount of bacteria should be present in the CSF to be present present in the microscopic examination. You can also take the CSF sample for rapid latex agglutination test, where the latex particles are coated with specific antibody against, say, Streptococcus pneumoniae, Haemophilus influenzae, E. coli. So there are commercially available kits for detection of antigen, CSF antigen in the diagnosis of acute meningitis. And this latex agglutination test detects the antigen in the CSF, but the sensitivity of this test vary between 60 to 70%. And lastly, you can do polymerase chain reaction and try to detect the DNA and identify the organism. In addition to this, of course, you have the blood culture, and the blood culture is the gold standard, as I told you. But the problem with the blood culture is that even a single dose of antibiotic will invariably kill the bacteria, and you will not be able to isolate the organism. But in gram strain, in latex agglutination test or PCR, you should be able to see the footprints of the bacteria. So if you see a gram positive diplococci and a large number of polymorphonuclear segmented nuclei of WBC, you can suspect that this is a Streptococcus pneumoniae infection, capsulated lanceolate shaped bacteria. That is, you suspect that this is a Streptococcus pneumoniae in pairs. Or you can see a gram negative bacteria, bean shaped organism, and large number of polymorphonuclear lymphocytes, and this can be a gram Neisseria meningitidis. This polymorphic type of picture with large, long, elongated bacilli with, say, coccobacillary form of the gram negative bacteria one can always suspect this to be a Haemophilus influenzae, because Haemophilus influenzae gram-negative bacteria in the CSF can present as a polymorphic bacilli with multiple different kind of morphological pictures. Very small coccoid bacteria or elongated gram-negative bacteria, along with the large number of polymorphonuclear leukocytes. What about the treatment? Based on the antibiotic, whether it's the gram-positive bacteria, whether it's a gram-negative bacteria, specifically for Streptococcus pneumoniae, penicillin group of all kinds of penicillin group of drugs, the beta-lactam group of drug is a good choice. But in recent years, Streptococcus pneumoniae has shown very large resistance to penicillin. So you see penicillin resistant bacteria in some countries like South Africa, South Korea, or in the US. A large number of bacteria, maybe up to 25% of this bacteria will be resistant to penicillin. So in this situation, the other antibiotic like third generation or fourth generation cephalosporins along with other macrolides etc. can be utilized for Streptococcus pneumoniae. Similarly, in ICA meningitis, one can try the beta-lactam third or fourth generation of beta-lactam group of organisms. Similarly, for the other organisms like Haemophilus influenzae, group B Streptococcus, third generation cephalosporin group of drugs, along with the combination of gentamicin or amikacin can be given for treatment of acute bacterial meningitis. Once in a while in neonatal meningitis, you can have Listeria monocytogenes, as I told you. So Listeria monocytogenes, fortunately, is still treatable with beta-lactam antibiotic. Penicillin along with the aminoglycosides like gentamicin, amikacin can be a good choice. Staph aureus, as I already mentioned, the Staph aureus sometimes can be methicillin resistant, specifically in hospital setting where it is causing post-traumatic acute bacterial meningitis, post-surgery acute bacterial meningitis. This can be treated with vancomycin or other groups of drug for Staph aureus. We have to understand that the prevention is always better than cure. So if we can prevent the meningitis, acute bacterial meningitis, we can prevent a large amount of mortality and morbidity. And as I told you that the three commonest organisms that causes acute bacterial meningitis, both in the adult as well as young children, are Streptococcus pneumoniae, Haemophilus influenzae type B, and Neisseria meningitis. And against all three of them there are excellent vaccines, and there are excellent conjugated vaccines. Streptococcus pneumoniae have a polyvalent conjugated vaccine, Haemophilus influenzae type B have a conjugate vaccine, and Neisseria meningitis is an excellent conjugate vaccine against serogroup A, or in combination of quadrivalent vaccine or bivalent conjugate vaccine. And as I already told you, a conjugated vaccine against Haemophilus influenzae B has drastically reduced the number of acute bacterial meningitis due to Haemophilus influenzae worldwide. Similarly, Neisseria meningitis vaccine, serogroup A vaccine, has reduced the number of acute bacterial meningitis due to serogroup in the sub-Saharan Africa. Thank you.